Okay, so our topic is rhythmical excitation of the heart. So this is the specialized excitatory and conductive system of the heart. So when this system functions normally, the atria contract about 1/6 of the second head ahead of the ventricular contraction, which allows filling of the ventricles before they pump the blood through the lungs and peripheral circulation. So another special importance of the system is that it allows all portions of the ventricles to contract almost simultaneously, which is essential for the most effective pressure generation of the ventricular chamber. So this is how the electrical system of the heart will start. So just listen.
Action potentials originate in the sinoatrial node and travel across the...
Can you hear it? If you cannot hear it, please use your earphones. Can you hear it?
wall of the atrium from the sinoatrial node to the atrioventricular node. Action potentials pass slowly through the atrioventricular node to give the atria time to contract. They then pass rapidly along the atrioventricular bundle, which extends from the atrioventricular node through the fibrous skeleton into the intraventricular septum. The atrioventricular bundle divides into right and left bundle branches, and action potentials descend rapidly to the apex of each ventricle along the bundle branches. Potentials are carried by the PURKINJE fibers from the bundle branches to the ventricular walls. The rapid conduction from the atrioventricular bundle to the ends of the PURKINJE fibers allows the ventricular muscle cells to contract in unison, providing a strong contraction.
Okay, so sinoatrial node is a small
Ma'am,
flattened ellipsoid strip of
ma'am,
specialized cardiac. Yes?
ma'am, actually, a lot of students are can't join the class because of the limitation, ma'am. Can
Yeah,
we start
so
another Zoom link?
yes, yes. I'm recording this. I will be posting this in our classroom later.
Okay, ma'am. Thank you, ma'am.
Okay.
Ma'am, what about the attendance, ma'am?
Attendance, I'll post the attendance later in the classroom. They can fill that up.
Okay, ma'am.
Okay?
Okay,
Okay,
ma'am.
so
Thank you, ma'am.
to continue, sinoatrial node is a small flattened ellipsoid strip of specialized cardiac muscle. So it is about 3 millimeters wide and 15 millimeters long and 1 millimeter thick. It is located in the superior posterolateral wall of the right atrium, which is immediately below the slightly lateral of the opening of the superior vena cava, and there is no contractile muscle filaments, and we call it the pacemaker of the heart. So this is the sinoatrial node. As you can see, this is located in the junction of the superior vena cava, or opening on the lateral side of the superior vena cava, and it is on the posterolateral wall of the right atrium. So this is the rhythmical discharge of the SA node fiber. So the action potentials recorded from the inside of the sinus nodal fiber for 3 heartbeats, and by comparison, a single ventricular muscle fiber action potential. Note that the resting membrane potential of the sinus nodal fiber between the discharges has a negativity of about negative 55 to negative millivolts, in comparison with the negative 85 to negative 90 millivolts of the ventricular muscle fiber. So the cause of this lesser negativity is that the cell membrane of the sinus fibers are naturally leaky to sodium and calcium ions, and positive charges of the entering sodium and calcium ion neutralizes some of the intracellular negativity. So next is your AB nodal. So your AB nodal is composed of three. There are composed of AB nodal nodes. So this is the organization of the AB nodal atrioventricular node. So your AV nodal is composed of three internodal pathways, no? Your anterior, the middle, and the posterior internodal pathways. The number represents the interval of time from which the origin of uh, the impulse from the sinus node, rapid velocity of conduction of these bands is the presence of specialized conduction fiber. These fibers are similar to even more rapidly conducting Purkinje fibers of the ventricles. So acts as a insulator to prevent passage of the cardiac impulse between atrial and ventricular muscle through any other route besides the forward conduction through the AV bundle. So your AB node, it has a capacity to delay the transmission of impulse from the atria to the ventricles. And it allows time for the atria to empty their blood into the ventricles before the ventricular contraction begins. It is located in the posterior wall of the right atrium, which is immediately behind the tricuspid valve. So if you will note in the ECG, the normal value of that is 0.16 seconds. So this is your where your location of your AV node, which is located in the posterior wall of the right atrium immediately behind the tricuspid. So if there's a problem in your tricuspid valve, you will have your arrhythmia, no, secondary to the damage to your atrioventricular node. Next, your ventricular Purkinje system. So these are very large fibers, even larger than the normal ventricular muscle fibers, and it transmits action potential at a velocity of 1.5 to 4 milliseconds. Very high level of permeability of the gap junctions at the intercalated disc between the successive cells. So there have a few myofibrils, and this is where your Purkinje fibers are located. Next is your left and right bundle branch. So it lies beneath the endocardium on the two respective sides of the ventricular septum and spreads downward toward the apex of the ventricle, progressively dividing into smaller branches. It has 0.03 seconds from the bundle branch into the ventricular septum to the termination of the Purkinje fibers, and the entire ventricle have 0.06 seconds amount of uh, the fiber, no, of the left and right bundle branches. So after penetrating the fibrous tissue between the atrial and ventricular muscle, the distal portion of the AB nodal passes downward to the ventricular septum for about 5 to 15 millimeter toward the apex of the heart. These branches in turn course sidewise around each ventricular chambers and back towards the base of the heart. The end of the Purkinje fiber penetrate about one-third of the way into the muscle fiber and finally become continuous with the cardiac muscle fibers that lie beneath the endocardium on the two respective sides of the ventricular septum. It spreads downward toward the apex of the ventricle, that progressively dividing into smaller branches. No, if you notice, if there are divided into left and right, so you will note that there is a small branches, of the bundles that distributed along the ventricles. So this is the transmission of the cardiac impulse through the human heart. So the cardiac impulse of the transmission impulse through the heart, the numbers on the figures represent the interval of the time, the fraction of seconds, and the lapse between the origin of the cardiac impulse in the sinus node, and it appears at each respective point in the heart. Note that the impulse spread at the moderate velocity through the atria but is delayed more than 0.1 second in the AB nodal region before appearing in the ventricular septal AB node. Once it has entered this bundle, it spreads very rapidly through the Purkinje fibers on the entire endocardial surfaces of the ventricles. Then the impulse, once spread, slightly less rapidly through the ventricular muscles to the epicardial surfaces. If you notice in this diagram, there are numbers, no? That numbers represents the interval wherein once the action potential starts in the SA node and the time that will reach, no, the different parts of the heart, no. So the hardest part of the heart that can reach the impulse is the apex, no, which is 0.22 seconds. So this value is important in reading the ECGs, no, the normal values of the ECGs. So this numbers represents the normal value of each wave, no, in your ECGs. So the ectopic pacemaker, so this is the EB node or in the Purkinje fiber, which is abnormal sequence of contraction of the different parts of the heart. So in this is the normal ECG, no? You will note that there are P wave, QRS complexes, T wave, and each wave is represented by each part of the heart. So your P wave represents the atria, the QRS and the T wave represents the ventricle. Your PR represents your AB node, no? And your QRS represents your ventricles. So, what are the indications for ordering an ECG? So, you order ECG to determine the cardiac rate, to accurately define the cardiac rhythm, to detect the signs of chamber hypertrophy, and to diagnose old or new myocardial infarction, and to identify intracardiac conduction disturbances, and to aid in the diagnosis of ischemic heart disease, pericarditis, myocarditis, electrolyte abnormalities, and pacemaker malfunction. So, your ECGs are composed of different colors, no? So your red, you place it in the right arm, yellow in the left arm, and green is the left foot, and black represents the ground. You usually place it on the right foot. So aside from your limb leads, you have your chest leads, no? In pediatrics, you have your three additional leads, no? Wherein we usually order it as 15 lead ECGs. Okay, so your ECG is composed of big squares and small square. So your small square, the value of that is 0.4 seconds, and the big square is composed of 0.2 seconds. So your segment and interval in ECG are different, no, from each other. So your PR interval is the start of your P and ends with the start of your Q wave, while your PR segment starts at the end of the P and ends at the start of the Q wave, no? So your P wave represents your atrial depolarization. Your QRS complexes is your ventricular depolarization, and your T wave is the ventricular repolarization. We also have our TA wave, which represents the atrial repolarization. So your P wave, QRS, and T waves are represented by each wave or each depolarization and repolarization of the heart. So your P wave is a positive upright in all leads except ABR. The duration is 0.1 seconds or less. The amplitude is zero point 0.5 to 0.25 millimeter. It is smooth and rounded, and a QRS complex normally follows each sinus P wave. So your QRS complexes, your Q wave is the first negative deflection, the polarization of the interventricular septum, and your R wave is the positive deflection, and the S wave the negative deflection after the R wave. So the duration is 0.1 second or less. The amplitude is RMS 15 millimeter. Can you mute yourself? Q wave is 25% of the R. So the shape is narrow and sharply pointed. T wave, which is in bleed B1, usually inverted but upright from age 3 to 10 days and adolescent. The duration is 0.10 to 0.25 and the amplitude is less than 5 millimeter. It is rounded and slightly symmetrical and always follows a QRS complexes. The U wave is the final stage of repolarization. It is usually upright, but the duration is undetermined and the amplitude is less than 2 millimeter and always smaller than the T wave. It is rounded and symmetrical. So your PR interval is the time from the onset of the atrial depolarization to the onset of ventricular depolarization and includes the P wave and the PR segment. The duration is heart rate dependent, but the value is usually 0.12 to 0.2 second. So if it is more than zero point 0.2, it is already, we call it the black, no? First degree, second degree, or third degree AB black. Where QT interval is the time between the onset of ventricular depolarization and end of repolarization. We call it the refractory period and it is also heart rate dependent. The normal value is less than 0.5, 45 seconds. So this formula, we call it the Bassett's formula. This is important in knowing the normal value of your QT interval, no? So we have your QT actual and we have your QTC corrected. So we divided into the RR interval, the square root of that, you divide it into QT interval. So the value for this is the one that being used if you want to know if there is a prolonged QT or short QT. Next is your ST segment. So this is early part of ventricular repolarization. The duration is zero point 0.2 seconds and the amplitude is isoelectric. Your ST segment is important in determining if you have your coronary artery disease, no? Or we call it the myocardial infarction. Your TP segment, this is the baseline reference of ST segment elevation or depression. This is usually used if you have your myocardial injury or your myocardial infarction also. So again, this is your ECG and your ECG are composed of P, QRS, and ST, and each wave has our own PR interval or segment. Your ST segment is also different from your ST interval, no? Your QRS interval is also different from your QT interval. Okay? So, your ECG again is composed of big square, which is composed of 5 small square, and each small square, the value of that is 0.4 seconds and the value of the big square is 0.2 seconds. So, you will know how to read ECG once you reach your second year, no? So, I'll just discuss here the importance of knowing the segments, no, in your ECGs. Uh, Later in our lecture, I will shift our meeting to Google because I thought that you are only 80 because Ethel told me that on the enrolled student are only 80. How come we are already 100? Raj,